Dear participants, welcome to today's webinar on the implementation of novel biomarkers in critical care routine. My name is Deborah Bergmann and I'm responsible for marketing and sales at Swingotech. It's my pleasure to host today's session and to welcome Professor Dr. Gernot Marx to give us some real-life insight in the process of changing standard procedure and on how he handles change management in the hospital. Professor Marx is a full professor of anesthesiology and critical care medicine and the head of the Department of Intensive Care Medicine and Intermediate Care at the University Hospital RWTH Aachen. He is very well engaged in medical societies for intensive care and the former president of Interdisciplinary German Society of Intensive Care and Emergency Medicine. His professional focus and interest is on artificial intelligence, telemedicine, and sepsis. And this is actually also how I got to meet Professor Marx and his team. It was in the context of a sepsis study, which the university participated in. And in this context, I was able to present our biomarkers. And it seemed that kidney function biomarkers are certainly a topic of interest for the ICU departments. And this is now quite some time and years ago, and I'm very glad I got to work with him and the trusted people around him. And it's been a very great and interesting process to watch and walk on the steps of implementing our kidney function biomarker penKid in clinical routine. And before handing over to Professor Marx, I think it's safe to say that at the beginning of a change in practice, a trustful cooperation builds the base for success. And with this, I would like to thank you, Professor Marx, for sharing your experience today with the participants, which hopefully will motivate others to give novel diagnostics a chance in practice and to manage the jump from bench to bedside. So,
thank you,
please.
For this kind introduction and also for the possibility to present here some thoughts today about the implementation of a novel kidney function biomarker in a clinical routine. And really, it has been already quite a journey, a joint journey. And I think this is very important, as you just indicated, that we are collaborating in order to improve diagnostic of critically ill patients and also enabling therapy in order to bring more patients, critically ill patients, back to life. So, dear colleagues, thanks very much indeed that you spent some of your valuable time. I will present roughly 20 minutes, and then we have a decent time to address all your questions and comments, which you can put in the chat as indicated. So I will start my presentation with some thoughts about how we get innovation into clinical practice. And I think it's fair to say that we have to differentiate between novel therapies and novel biomarkers. If we talk about therapies, a drug for an example, then it's really depending on the efficacy which we prove in clinical studies. And obviously we have an indication for this drug. And then when we have proven the efficacy, then it's get it implemented. Although having said that, especially in our ICU environment, it's a long time ago since we had a new innovative drug, and this is probably another issue for another presentation. When we talk about novel biomarkers, this is basically driven by our interest in that we have a need for better diagnostic, and a better diagnostic is either more specific, more precise, but especially it is important that a biomarker is better than we. When a biomarker is, for example, like if you're thinking about an infectious disease, and if a biomarker is only basically supporting our clinical abilities, then it's not really better than standard of care and clinical judgment. Then we can save the money. So a novel biomarker need to be faster or better. If you think about the procalcitonin, we can identify an infection better. We can sometimes differentiate between infection and inflammation. And especially with procalcitonin, we had evidence that we can guide our antibiotic therapy. And this is obviously very important. And over the years, since mid of the 90s, when I came along first time with this new biomarker is now more or less in the clinical routine, but it also reflects how long it takes until we get something into the clinical routine. We are talking about really years. Now, let's have a look on a more general, from a more general perspective. First of all, if we think there is a need, then our expectations are not longer being met, and we need to be, yeah, we need to be in the position that we are happy to accept that we have to change. So we unfreeze our routines. Nothing has got more strength than our clinical routines, how we're doing things. So we do not really like to change. And in order to do so, we have to be happy to do this. And this is probably only the case when we really feel there is a need to change. There's our expectations, our we are not convinced anymore that, for an example, the biomarkers we have in our armamentarium are good enough to meet our clinical expectations, and we need to change. And this is then present out of a sudden. To do so, you really have to be, well, open for new ideas, for innovation, and also you have to be happy to take the not only the opportunity, but you need really to guide this and to have the power basically to do it, because obviously change management is not easy, and it costs a lot of effort and time and power really in order to do so. So once we have decided that there's really the need in order to do these changes, we are on our way. We are moving and we're looking for solutions. And for one example, um, the idea here is that let's put the procalcitonin for an example. Then there was a need really that infectious disease are not better really diagnosed, and we need to do behaviors and processes. What have we done so far? What is the downside? So it took too long. Or if we are talking about, for an example, patients with acute renal insufficiency or even failure, it's very difficult for us to diagnose it early or to really diagnose it during our renal replacement therapy. So we have gaps we need to fill, we need to improve. And once we have decision that, okay, we look for solutions and maybe we find something we want to explore, then when we are on our way, it takes a lot of effort, because you need really to identify how I do it, how I read, what kind of processes of my clinical routine needs to be changed, who needs to be involved. Well, involved needs to be all of our team members, and this is obviously depending on our size of our units, quite a number of people, and you really need to involve all of them, because otherwise it's not working out. And this needs to be not only being established in terms of standard operating procedures, it needs to be explained, it needs to be trained, it needs to really get into the mind of the people, and they need to be convinced, not only saying, okay, my boss is telling me something. It need to be our team members really need to be convinced in order to be on a successful way of changing and implementing new innovation. And obviously, when you have done this, you need to freeze this up on a higher quality, on a higher level. You have to achieve a new level of stability, because you cannot change and change and change. You need from time to time making a stop and controlling basically whether your new level of quality is and treatment protocols is sufficient and is achieving its needs. And then you are quite it's recommended really to stay there for a while until you unfreeze again for a new change. So we are talking here really about months and maybe even years. So for our patients, it's really our responsibility as intensivists to identify the needs and to begin and start the change. When we are not doing it as the ones who are responsible for our patients, nobody else will do it. Now, I quite like this picture. It's about, well, illustrating to you how difficult it is to implement a novel biomarker. And here it's basically it's not only one hurdle, we have a couple of hurdles in a row. And if you just, well, in a way, it looks like it's nearly close to impossible to implement a novel biomarker, but it really needs to be a strong biomarker in order to successfully overcome all these hurdles. Well, first of all, you need to identify and verify the need. And for an example, here, and we have seen several biomarkers in the area of kidney insufficiency and kidney failure, because we are not really good with the ones we have got so far in terms of creatinine, for an example. So we are strongly convinced that these parameters are not sufficient. We need new biomarkers, so the need is identified. Then obviously you need to have some sort of evidence, basic research evidence, discussion with experts, and then evaluate appropriate biomarkers in our biobanks, and then really evaluate in an intervention with patients and identify good endpoints which are clinically meaningful. And then basically it's about implementation. And the good news for the penKid parameter is that, as you can see here in red, we are already in the stage of implementing these new biomarkers in the clinical scenario. In other words, penKid has overcome already many hurdles, and in a way, at least here in Aachen, it's already implemented in the clinical routine. So we have already overcome as well the fifth hurdle, and now looking towards the last one in terms of cost effectiveness and clinical application. So here's a SWOT analysis in order to describe to you how we implemented this new kidney biomarker penKid. Obviously, we are using many biomarkers already. They are part of our clinical routine in the intensive care environment. We have identified that to diagnose kidney disease, kidney failure earlier and more precise is an unmet medical need. And we have been in discussion, not only us, but also others. So, and I think intensivists are always quite open to innovation when they see the chance that we can improve diagnosis and therapy for patients. We want to have it, we want to apply it to our patients. And obviously biomarkers, when they're good ones, they're valuable because they add additional information we don't have out of our clinical abilities and to complete our clinical assessment and clinical picture. We have discussed just before Corona pandemic started end of 2019 with the company that we should do really we had already research data, so we wanted to go into the clinical routine, and it has to be said that we started just when Corona pandemic started, also in the year 2020, and I must say I'm quite happy that my team was able to do it together with the support of the company in order to implement this into clinical practice in order to trying to improve patient safety due to the more accurate renal function assessment. Obviously, to implement a new biomarker is quite complex because you not only need and we come to this in a due course, you need also a lot of technology, IT, laboratory, and there's quite a bit of implementation work to do with many other departments, and this is obviously Well, it's time consuming, and also it's not coming for nothing. Let's put it this way. But we had the opportunity really to implement here a biomarker which is more precise and accurate in assessing renal function. Well, a threat, I would rather say a challenge is, as I indicated before, that you need to really train and train and train constantly your doctors, your nurses, the lab team, IT team. So there's and as we know, we have a lot of rotation. We have always new members of staff, so it's a continuous a challenge in order to bring everybody to on scratch. And obviously also we have here new costs, and the cost effectiveness needs to be proven. As for an example, with procalcitonin, we did with antibiotic cost reduction. And also what we had here in Aachen, as Aachen, the University Hospital of Aachen was now the first university hospital, I think, in the world, where we had implemented into clinical routine. We had not really somebody to copy. So no operation procedures has been described before with this particular marker, and therefore it was quite a journey and a challenge. Here you see a picture how we did it in reality. You see on the top a picture of our PDMS system, and we implemented the penKid value just above creatinine and BUN. And so it was basically visible for our team, and we did the measurement once a day. And with this routine measurement between Monday and Friday, and we had basically in our surgical and medical ICU, including 75 ventilator beds, plus our weaning unit with 18 beds and our intermediate care units. So I would, this is then, let's say, 140 beds in total. And we measured penKid in approximately 80 patients per day. In total, it has been 4,200 patients, and we had 18,000 penKid measurements in this course between 2020 and April 22. And we had now many of these data available for clinical routine evaluation. One very important issue in order to be successful, that you have to include really everybody, and everybody starts with your medical and commercial director. You need to convince them that this is potentially at least a very good idea to improve here and to be first adopters. And when you have done so, then head of laboratory and head of IT, your team members. So in our case, I discussed it with the director of the different medical departments, gastroenterologists, cardiologists, neurologists, etc. Because only when you do it as a team, especially in intensive care, you are then successful, and also obviously all of your team members as well. And IT, I stress it again, is also very, very important. Without a proper support of IT, you are not able to implement a new biomarker successfully, because it needs to be, the team needs to feel that it is easy, and that they rather have that it's something easier than before. And if there's more stress and or it's bulky with the IT, then basically you have lost it from the very beginning. So this is very important, really. Now coming concrete to the penKid routine use. So we tested this as a part of a standard morning routine, so that there was no extra request. I think this was very important in order to ease up. Obviously, we had to use a special, or not a special, but a monovet for hematology in order to get it measured by our lab colleagues. And before then, obviously, the sample was not available. Another very important point was that we measured early in the day in order that we have the result available when we're doing our consultant rounds, ICU rounds, in order to have then an impact to the therapy of the patient, and having enabling a daily review of the results of the penKid during the ward round. And before that, obviously, personnel didn't use this test. And after now this test phase, implementation phase, where we have been successful, now we are just started beginning of this year to really transfer it now to in the clinical routine practice. So it's like any other biomarker we are using and paying also, and we implemented it in a standard operating procedure. So our staff knows when to measure this new biomarker, and the things which are upfront, basically what we need to address in the due course is the issue of reimbursement, and especially in Germany, but I think it's all over the place. This is very difficult because money is short, and we need to convince the regulatory boards and also using the support of our medical societies in order to get this innovation really reimbursed, because this is obviously important in order not to get early adopters, but also to broaden it up and to enabling intensivists to support patients with renal insufficiency or even failure to get better treated. So before we did this implementation of the penKid, we need to realize that there was no diagnostic test which we could use during dialysis. In our test phase, implementation test phase, we had more than 400 patients with dialysis, and in total more than 3,500 days of dialysis. And I just present you an example of one of these patients, and you see initially the patients here on dialysis. So these are the red dots you can see, and you see the measurement with the black dots of penKid in the upper graph. And we started with penKid values of nearly 500 picomole per liter, and normal value is below 80. And you see that it's basically constantly during the different dialysis terms, but measurable. But then you see the decrease, and then also a further decrease, then more slowly, and then we could wean off dialysis, and then the value was close to normal after a couple of days. That means during dialysis, we are able to measure kidney function, and also we can measure the when there's an improvement of kidney function, and also we can then really identify the right point of time when it's possible to wean dialysis. So far, it was just clinical judgment without any rationale, and this is really a huge positive effect, which is only given to us or enabling us by the new biomarker penKid. In the graph below, you see the creatinine measurements, and there clearly you can see in this patient, you have an increase of creatinine, then you have dialysis, then it's been washed out, going down, then you have a pause, and it's increasing again, then new dialysis, again down. So you have basically up and down, and you are not able to identify what is how is the kidney function, what's the situation, is there an improvement, is there a deterioration? So basically no value of this parameter here at all. So to slowly summarize, it's basically able to, if we move forward and improve kidney diagnosis, what do we want to achieve? We can implement GFR based on the penKid. We can adopt penKid interdisciplinary. We can regular analyze routine data of penKid to better describe the application. What we do need is a regular reporting and quality check what we have achieved. Is the biomarker really doing the job? This is, I think, very important that we are not just implementing and then stop checking ourselves, but it needs to be a continuous quality circle. The ideal is obviously the automation of penKid in a central lab on our machines. So far, we did it with an extra machine in a central lab, and it's also possible to do it with a point of care measurements to at least to start with to get this parameter introduced in the intensive care environment. Obviously, what we need to do is address the reimbursement together and also to prove cost effectiveness. But if you think about it, if you really save a couple of dialysis days in our patients, it should be possible to also prove cost effectiveness in the due course. So to summarize, application where we here used in Aachen, the penKid was the monitoring of kidney function during dialysis and support the weaning decision or enabling weaning decisions. So this was basically our key finding that this is really possible. In addition, we found that it is possible to earlier detect worsening and also improving of kidney function in our critically ill patients. This was also very helpful. And because when we are earlier detecting deterioration, then we can also early start risk stratification and maybe when to start dialysis and also when to end. A huge potential I can see in addition is that we have a guidance parameter for nephrotoxic drugs because penKid is enabling us to demonstrate really sensitive changes of the kidney function. And last but not least, but we maybe need a couple of more data. So we have assessment of the glomerular filtration rate. And this includes the creatinine blind window. This is interesting for our patients in the adult scenario, but also in our newborns and small children. Here might be another potential in the due course. And really, I think the use of penKid improves the quality of care in our most critically ill patients with worsening of kidney function because it faster and more precise detects worsening of the kidney function and enabling us, especially when they are on dialysis, when they're improving with the kidney function, when we can wean dialysis off. In total, it therefore increases patient safety and care. Thank you ever so much.
Thank you, Professor Marx, for these interesting insights. I'm very glad I was able to also follow the process because I think it's a quite crucial step to go from a study setting into real life. And I think the use case or application that you mentioned, so the monitoring of renal function doing dialysis, is something that we wouldn't have planned for in a clinical study. So the real life application is something that brings us forward together, the company, but also the clinical or the clinicians in order to understand how to use a biomarker. So everybody from the participants, feel free to add your questions to the chat. I see there's already some questions coming up. So one of them, Professor Marx, is how did you ensure to get compliance from your medical staff? I guess this relates to the question how they get to start using it, look at it, and applying it to decision making.
Mm-hmm. I mean, first of all, what is beneficial if you have a good team spirit to start with. And I mean, intensive care teams, unit teams are always interested to improve diagnosis and therapy of care of our patients. And we basically discussed it a lot. We demonstrated the data we had so far from the preclinical side and also from clinical investigations. And then it was very easy. And just really to have this route of where we try it out in the clinical routine, and then we put together not only research data but also routine clinical data. And in the end of the day, this is sort of real world evidence. And with this, it was then very easy to that I didn't have to convince them. It was convincing on its own, because the data was, and you, what also was very convincing, that we had it was part of our routine when we discussed it with our surgery colleague, for an example, with our cardiac surgeons, about when to stop dialysis therapy, for example. This is what people basically, it was part of the daily routine, and then it was basically convincing on its own. So that was really easy.
Thank you. I think this also answers another question. How long did it take you to be convinced for penKid? Maybe you can even remember a patient where you saw where penKid delivered some extra information.
Well, I must say, from the body of evidence we had so far, I was convinced, and but there's also always this step from research to clinical routine. This is quite a step, even if the evidence is very convincing. But if something, and I must say, I have so far just myself experienced this with just one other parameter. This was procalcitonin. When I moved in the 90s from my home university in Hanover to Liverpool, I really missed procalcitonin. And if I had to move now from Aachen to another place, it's not coming, no worries. I would miss penKid, because with penKid, I really in the position to discuss and decide when to start dialysis and when to end it. And this is really something I've missed so far, and this is now being supported heavily with this new biomarker.
All right, thank you so much. Another question going in this direction is, what is the minimum level of clinical data that you would require to adopt a novel diagnostic test?
Well, you need some, you basically, before you decide to go the way towards routine implementation, you need to be convinced by the research. So it needs to be really a proper sustainable body of evidence in the lab with animals, and then with first data from the clinical scenario. So we had several studies where we had really a very convincing data that there's something in it. But in the end, the routine decides. If before I pay money for anything new, I need to see that it's really working in daily life, in daily clinical practice, because I'm not doing it because of an RCT. Basically, when I do not see anything happening, then it's really difficult, and it's difficult also to convince your team. But when they see it's working and it's helping me, then it's easy.
I understand. You actually mentioned also another point, to be willing to pay for it. I think almost all hospitals struggle with this question. You mentioned the money is short. So one question from the chat is, when do you expect reimbursement to become possible? And I guess there we have a long timeline where we also need to work on as a company, but maybe from your perspective, from the medical societies, you can comment on maybe the process rather on the timeline.
Yeah, the process. I mean, if there is a group of early adopters and a general feeling of that this is something valuable, then it's time also for our medical societies like DV or DGI or others to support here and to go to the regulatory boards and to apply for reimbursement. And it usually takes some time. Usually the first application is not successful, but this will be, in the end, if something is really valuable and really convincing, then there's also a way like BNP or procalcitonin or other applications. And in terms of intensive care medicine, I think we are quite, I mean, if I think that how other medical, like the hematologists, for an example, they have a lot of money for their antibodies, and I think as intensivists we should really be we should really be in the happy to also sorry, I lost them. to fight for it basically, or to convince the bodies that also intensive care patients have the right for innovation, even if it costs a little bit more.
I understand. Thank you very much. Another more practical question is on how often do you recommend to test penKid, and what are the situations where you would retest the biomarker?
Well, if I have a patient where a patient multi-organ dysfunction, where I see that the normal renal markers are deteriorating, maybe urine output is deteriorating, high level of vasopressor support, then it's time to make a measurement and then maybe decision whether to and the cutoff value or normal value is below 80 picomole per liter. And then if it's really high, for an example, let's say 350, 500, even if the patient is then still having a urine output, I would recommend to start dialysis, for an example. Then during dialysis to do it maybe every 2 days, and then to see when it's coming down. And it's the weaning process, for an example, is probably another very important question. It's depending on the individual patient, obviously, but then when we see patient is improving, urine output is starting, then the level of 200 picomole per liter, this is the level where we start with weaning dialysis. Although having said that, this is limited experience and data, so we are in the beginning here. This is not rock stable. So we need still to make to collect the experience also from different sites in order to be more robust basically in our recommendations. But this is just the first report from our experience here in Aachen.
Okay, thank you on this question. Is it safe to say that you mentioned the clinical presentation? Is it safe to say that for now there was nothing or no in vitro diagnostic available that could support diagnosis of renal function during dialysis? And
Yes.
do you see any competition arising during dialysis?
I mean, yeah, I mean, obviously, but clear, yes. I haven't an alternative in my pocket. There are more or other new kidney biomarkers, but I have to say that so far we had no experience as convincing as with penKid in this clinical scenario.
And I guess there's an international question before we need to wrap up. So maybe 2 more questions I can do. PCT is less used in the US versus Europe. Do you see penKid in alignment in both countries in the future?
Well, this is a very good question. I must say, acute kidney dysfunction, especially failure, is associated with a very high mortality in the US as well as in Europe. And if we see here with a biomarker to really individualize therapy and to improve the therapy and really to save maybe patients, having more patients than with not end-stage renal failure, and maybe there's the window of less morbidity and maybe even mortality in the future. I would say this is convincing for all colleagues all around the world, not only the US and Europe.
And the last question, what was the trigger for you to decide to actually implement penKid in an SOP?
Well, this is very easy. I must say this is, I quite like standards, and I like quite that all my patients getting more or less similar therapies and diagnosis. So we have a lot of SOPs and guidelines, and there is putting it into an SOP makes sure that the team is using the parameter in the correct situations, and also not to use it too often or too less. So really, if it's indicated, then to use it, and then we can also just one sec.
Let's wait just a second to see if the technology is working.
Yeah. Sorry. So sorry to repeat. So it's important to put the penKid into an SOP is that I ensure as the head of department that my team is using the parameter correctly, that I for the correct patients, and then really use it, but not too often, not too less frequent, and also that we can control basically that the use is really being followed, and in order to ensure quality improvement. So this is very important. Otherwise, it's just random. So.
Okay. Yeah, thank you very much. I think this sums up also very well the presentation of today. Please correct me, but I understand that it needs quite some motivation. There needs to be a trigger to be motivated to change something, a strong team. From my experience, I understand there needs to be a champion, but you need to have the support from many stakeholders in the hospital to actually manage to bring it into clinical routine, to have it paid for, to have it standardized in an SOP, and it needs to be easy accessible. So therefore, I think this rounds it up. It is a challenge, but it's of great benefit for patients and clinicians to support decisions. And yeah, Professor Marx, thank you for coming in and dialing in today, explaining about your experience. And maybe if you want to have a final word for closure, it's all up to you.
Okay, thank you so much, Deborah. So thanks for investing the time and listening to my presentation, and also thank you very much for the very important questions. And I think we are just in the beginning here of the journey. We have done already some steps, some hurdles, but there's also a way to go, and I'm very looking forward together with all of you that we collect more data about this biomarker in the clinical routine, and to make a really robust a body of evidence of real world clinical evidence in order to improve our critically ill patients with renal insufficiency. And I'm I'm sure that this is possible using penKid, and therefore thanks again for your time, and looking forward to see you soon. Bye bye.
Bye bye.